started there's a huge crowd here, so we have the security issue that we had to deal with to control the crowd, but it's going to be okay. We're working our way through it. I hope you can all hear me online. My name is Dave Flum. Good morning. So the camera for this is right here, right? Camera's right there, so I'll look over there. Welcome to Grand Round, and it's my pleasure to do the introduction today. Grand Rounds is an opportunity, as Dr. Dellinger was saying, for us to come together as a department. We are coming together in lots of different ways, together in the same room, together virtually, but it's great to see you all without masks, and it's great to get together to share sort of the best of the department, and that's what Grand Rounds is all about. As some of you know, we use several of the Grand Rounds each year to showcase faculty who are surgeon scientists who are developing their research careers within the department. And so today is a great opportunity to have you meet Scott Brakenridge. Some of you know Dr. Brakenridge. If you've been at Harborview, you'll know Scott. But for those of you who don't, we have a lot of great campuses in the department. It's a great opportunity to meet Scott. Scott joined us right in the middle of the pandemic. So for many of you, this will be the first time seeing him, certainly without a mask. He is from the great state of Chicago. He got his medical degree at Rush, and general surgery training was down at UT Southwestern, and he came back here for trauma and critical care fellowship and he excelled in his fellowship. Afterwards, he became faculty down at University of Florida, and that was from 2013. And down at University of Florida, he really began his career as an NIH-funded investigator studying sepsis and helping to lead the core of the University of Florida Sepsis Research Center. We were lucky enough to recruit him back in 2021 as an associate professor here. And he is one of the handful of NIH-funded bench and translational researchers here within the department. His research is in a crazy cool area. It focuses on the folks who are injured, who fall into a pattern that all of us know where trauma is not an acute event necessarily, but really a lifelong event. These are folks who have chronic impact related to their trauma. And he's studying both the mechanisms of that, the ways to predict that, the way to personalize our trauma care so we can get better outcomes for this important subgroup of people. And he's studying everything from immunosuppression to precision medicine to get us better long-term outcomes in this important group. So very exciting research. I encourage any of the residents who are interested in research, exploring it, or finding out more to reach out to Scott. It's one of the best benefits of this Grand Rounds activity. Scott's also joining us in helping create this new division of research, which for some of you, this may be the first time you're hearing about a division of research within the department, where we are helping to bring together all the investigators, surgeon scientists, and staff who are involved in research to create better community, to build opportunities, to deal with the challenges of becoming a researcher, and to highlight that aspect of our mission, which we're really excited about. So Research Grand Rounds is part of that. So it's my pleasure to introduce Dr. Scott Brakenridge for that. Thanks, Scott.
Thank you, Dr. Flum. It's a pleasure to have a chance to speak at Grand Rounds again. I had the privilege last year, and I talked about my primary research program last year, and this year I thought I'd tell a little bit more of a story. There's going to be some science, so it's going to be more of a story and some things about lessons learned about turning lemons into lemonade. So just some disclosures. I'll be talking, the research I'm talking about was funded by the NIH, but also by a couple of different institutions and the NIAID. But more importantly, the disclosures I want to make is that a couple of lessons that we're going to talk through is that it takes a village. This just isn't me. This isn't a story of me. This is a story of a village of people. And this pandemic story that I'm not going to tell is not really specifically unique to me, nothing special about it. You've all lived it. But I think there were some lessons we learned from it. And as I mentioned, I think this talk, I didn't want to get lost, deep into the science of mechanisms of COVID, because I'm talking to a bunch of surgeons. But it's more about the lessons that we learned along the way. So as I mentioned, what is a surgeon doing talking about COVID-19? This is a question I ask myself almost on a daily basis between March of 2020 and through 2021 was, what is a surgeon doing research on COVID-19? And I think to tell that story, we gotta go a little bit back in time. And so what really kind of brought me to team science and what we've been working on for the last 20 years is really kind of centers around the question, is survival to ICU discharge a victory? And we see it all the time. We have patients that we get out of the ICU, we high five each other after a bad surgical course or critical illness course or trauma or sepsis. And we think that we get people out of the ICU alive, that it's a success. Well, inpatient mortality after critical illness and shock has significantly declined over the last 20 years. The survival after sepsis has gone from, say, 50% down to less than 15%. And severely injured trauma patients, the mortality, if you survive at least to the door, the mortality has gone from 25% down to less than 10%. So, but the question, as I proposed before, is, does survival out of the ICU equal success? And I'd like to pose to you that survival after critical illness it's not black and white, it's actually gray. And I know you guys see this. And so let's start with lesson one. It takes a village, or otherwise maybe known as surround yourself with good people who are a lot smarter than you are. We'll talk about that a little bit. My first village, at least as a faculty member down my journey of team translational science, was after leaving fellowship, my years here at UW and Harborview, to go to the University of Florida. I was recruited by Fred Moore, who's a famous trauma surgeon scientist, very accomplished, and he recruited me down to become a part of this growing village, which ultimately became the University of Florida Sepsis and Critical Illness Research Center. Brought a bunch of people together, from basic scientists, Link Moldauer down there on the left, who I'll be talking a little bit more about, and really he and Link, Fred and Link, really put together an incredible team to study the question that I was talking about. And we wrote a P50 grant around this, which funded our research program for about 10 years. And really we're centering our research around an observation. The observation was that the clinical phenotype of shock and multiple organ failure, what happens to these people, are changing. So over the past 30 years, the amazing advancements in organ support and implementation of evidence-based protocols that we've done in the ICU has significantly decreased in-hospital mortality. Patients are surviving. But the clinical burden of critical illness is shifting from early mortality and death from people in refractory shock and dysphoria, multiple organ failure very early, to a prolonged course of be stuck in the intensive care unit, just kind of sitting there smoldering, getting recurrent infections. And that's the course that we call the trajectory phenotype, if you will, that we call of chronic critical illness. Those patients that are sitting in the ICU greater than 14 days with persistent but manageable organ dysfunction. You can tweak with their vent, you can put them on CVVHD. But there's other things that we can't do much about. They have acute muscle wasting. It's a disease like cancer, almost like cancer cachexia. These patients have recurrent infections. They get pneumonia, UTI, then they get eclampsia. And they survive, most actually survive to discharge, but then they end up in long-term care facilities, LTACs, hospitals, and they have dismal long-term outcomes. And when you look at them, not their outcome at 30 days, but what are they doing at 6 to 12 months? And this state of chronic critical illness is characterized by the state that I like to call sepsis recidivism. These patients just keep bouncing back with infections, whether it's not within the ICU, or they end up coming back to the ICU, or they end up coming back from the hospital. And a third of patients admitted to the ICU enter this course of developing CCI. And these patients have threefold number of secondary infections. And even though their inpatient mortality is pretty low, as I was telling you before, less than 15% in sepsis, their one year mortality, which I'm going to show you again in a minute, is almost 50%. And 60% of these post-discharge deaths are from recurrent sepsis or non-resolving multiple organ failure. And again, these patients have dismal long-term outcomes. We get them out of the ICU, we think they're going to do okay. As I mentioned, this is for sepsis, patients who are in the ICU from sepsis. At the Sepsis Critical Illness Research Center, that P50 program that we have, what we did is we enrolled and studied 300 surgical ICU patients and followed them over the course of 2 years of follow-up over a 5-year enrollment period. And even though the 30-day mortality was 13%, if you follow that out, almost half of these patients that develop chronic critical illness at 1 year were dead. So is getting out of the ICU really a victory? And to summarize, because I know I kind of talked about this last year, but just to summarize kind of what we studied over that 10 years, kept trying to understand what's happening to these patients, is a syndrome which Fred and Link coined the persistent inflammation, immunosuppression, catabolism syndrome, or PICS. So, patients having a pro-inflammatory insult like sepsis or trauma, what the Glue Grant program that some of you may have heard about back in the early 2000s, which was a study of critically ill trauma patients, showed us that that these patients who have these pro-inflammatory insults like sepsis or trauma undergo this genomic storm within the innate immune system. If you want to use this cartoon thinking that inflammation is up and immunosuppression is down, we should be living at that homeostatic line. There's a genomic storm, an explosion of kind of dysfunctional pathways within the immune system. Now, previously, many of these patients would go into multiple organ failure and then die an early death. But that's, as we mentioned, that's going away. About a third of these patients, luckily, or sorry, about 2/3 of these patients will kind of reestablish that intrinsic homeostasis of their immune system and organ function, and they'll go on a course of rapid recovery. But that last third, still a significant amount of patients, somewhere between a quarter to a third of patients, will never really get back to that baseline. They'll have smoldering inflammation, they'll get progressive immunosuppression, which are current infections. They sit there, they waste away in the ICU, and they enter that trajectory of chronic critical illness, and ultimately they're discharged to LTACs, getting readmitted with current infections and die an insidious death, as I showed you, somewhere between 6 to 12 months later. And one of the mechanisms that we feel is really kind of driving this innate immune dysfunction is the expansion persistence of immature myeloid cells from the bone marrow in a process called emergency hematopoiesis, which probably helps us in the state of acute infection, but we weren't evolutionarily designed to survive hemorrhage or acute infection in general. And so this is kind of the adverse effects of a response that's meant to save you, but that we really weren't meant to survive. And my partner, Phil Efron, down there really built his career over the last 10 years, kind of showing that. So trauma and sepsis are diseases of the immune system. This is kind of what I was trying to tell you in the immune system. So, and immunomodulatory drugs exist. So use them, right? That's not use sense. Just start modulating the immune system. Well, we learned very painfully in the 90s and the 2000s, what you want to call the sepsis wars, where a bunch of clinical trials trying to use different immunomodulators, targeting different pathways that seemed really promising in mice and other model systems. And, what we found, you'll recognize some of these probably: Tigris, anti-TNF, anti-IL-1. Hey, let's block the inflammatory immune response and we'll save the day. We'll save all these patients. Well, none of this worked. And the question is why? Why could we not find this silver bullet? Why can't we modulate the immune system if we understand so much more about it? And one of the primary answers is that an effective precision medicine approach targeting specific mechanisms require the recognition of disease endotypes. And what does that mean? Well, that means mice are clones, right? They're all the same in a research environment. Humans are not. So our response to disease is heterogeneous. And so it's important to understand what a phenotype, the difference between what a phenotype and what an endotype is. So I'll throw those words around a little bit. A phenotype is what you see with your eyes, okay? It's a group of patients defined by a set of clinical signs and symptoms. It's what you see at the bedside, i.e. like that chronic critical illness. It's the most common thing that drives the management at the bedside, right? It's what we see with our eyes and the kind of simple data that we look at. But it does not necessarily reflect or give insight into the specific mechanisms at the level of an individual patient, just because of the heterogeneity of us as humans. So the endotype is what lies beneath. It's a group of patients defined by not by necessarily what you see. Sometimes they're similar or they're linked, but they're defined by the underlying biologic mechanisms. They reflect the difference host biology between individuals within the same clinical disease. They may look the same, but many of the mechanisms that are driving things underneath could be very different. And maybe that's the reason why trying to use very targeted therapies in patients that look the same has not worked. And this is what dictates the response of individuals to mechanistically targeted therapy. So understanding what the endotype of the specific patient is, even within a phenotype, is important if we really want to use targeted precision medicine type approaches. And so, a question that we were starting to ask was, us as a group, as a village, are there existing clinical practical methodologies available to reliably determine the immune endotype of individual sepsis patients, surgical sepsis patients? And so that village started to grow. And so Lincoln Moldauer, I mentioned, I just had the absolute pleasure of working with him and Fred together leading that research program. He is a basic scientist, immunologist, who just has an amazing clinical gestalt and just common sense understanding. And it was just an absolute pleasure to work with him. Just absolutely brilliant. And got together with a couple of scientific friends, Richard Hotchkiss, who's an anesthesia intensivist at WashU, and Chip Caldwell, who's at the University of Cincinnati as a basic science immunologist, got together, started asking this question, we have all these kind of basic science knowledge, but how can we actually translate this to clinical utility in a way that's going to be not only meaningful, but practical? And so the question became, are there clinical methodologies to assist in determining the endotype of an individual sepsis patient? And we do have fancy tools. We know a lot about the genomic and transcriptomic signature of patients with shock. We can characterize the immune system by, very sensitive flow cytometric cell phenotyping. But the problem is those are not those are not ready for prime time when it comes to clinical use. And we have problems we want to solve. What can we do with the technology we have available? And so initially we started focusing using ELISpot, which is essentially like a single cell ELISA. And what it is, it's a very practical and timely and dynamic functional measure of both the innate and the adaptive branches of the immune system. And we can use, and I'll show you in a minute, we're able to use a whole blood assessment, just 10 microliters or 10 mils, of 10 microliters of blood from an individual to determine their cellular response, both their cellular response, i.e. how is the expansion of a certain cell populations, but also how they function. And importantly, it facilitates the rapid testing of ex vivo response to therapeutics. We can test agents in the dish from the patient's own blood and see how their immune system may or may not respond. And importantly, it was an existing FAA-approved laboratory platform already based using for tuberculosis and fungal infections. So it's available and FDA approved for use, clinical use. All right, and so as many good mentors do and senior scientists do, they gather a group of young, hungry people, junior mentees, to do all this fantastic work for them, right? And so Link, gathered together a team. Myself, I mentioned Phil Efron before, as my partner at UF the last decade. And then Richard got together Ken Remy and Monty Mazer, who actually were very interestingly pediatric intensivists. And then Chip got Vanessa Nobolini, who is a trauma surgeon who's now at the UT Southwestern. She's an MD PhD, another fantastic physician researcher. And so put together, we put our heads together around this question and said, okay, so let's submit a grant, try to answer this question. So we submitted and got funded in R01 to compare ELISpot to standard prognostic markers and metrics and employ it in a predictive fashion, not only for prognosing how patients are going to do, but can we predict who is going to respond to certain therapies that may modulate the immune system, try to change those trajectories I was showing you. So the first question, we have to get through some technical issues when you're developing technology. And so we want to see, can we make it a more clinically practical without compromising the accuracy of being able to endotype patients? Because ELISpot is mostly used in the context of separating white cells from blood, peripheral blood mononuclear cells, and studying those. But that's not super practical for a clinical application. It takes several hours of processing. It takes a lot of person power. So what we did was Monty Mazer and Ken Remy at WashU, with everybody working together, started working on a protocol to do this just from drops of whole blood, and developed a protocol to easily perform and compare the results to isolated PBMCs. And we were able to show that we were able to develop a protocol to use this technology in a much more clinically relevant fashion. And that the results across, using whole blood and using more separated cells was essentially the same. So, okay, now the ball is rolling. We're picking up speed, starting to get exciting. We're making some progress. Then overnight, everything changes. March 2020. Okay, I'm sure you all remember. And overnight, our world was different. Research labs shut down all over the world. All of you who have been here, or maybe as students, some of the residents during that time, but we got consumed in our hospitals as they got overflowed with just patients that were just absolutely sick and dying of respiratory failure and multiple organ failure. I was seeing my friends pop up on the news, and just the fabric of the society seemed to be tumbling and falling apart. You've all lived it. And so lesson number 2, in times of crisis, be prepared to pivot. All right, nothing good about idle hands, right? Those of you who have kids that are home for the summer, you understand that quite well. So what are we going to do when we're sitting around? I mean, now we weren't busy. Clinically, of course, we were absolutely slammed, but intellectually, and our minds are sitting there spinning. So we got to start thinking. We got to start addressing the problems at hand. And so during the lockdown, we were in the early weeks and month or so, we started using our existing knowledge of sepsis and trauma and shock and saying, like, well, how does this relate to COVID critical illness? And so we started pondering and pontificating and just thinking about what was going on and looking at just kind of some clinical observations and the things, some of the little bit of data that we knew. And the de facto dogma of COVID-19 was this was death by cytokine storm. Huge inflammation, and you die a pulmonary inflammatory death. And that was just kind of the de facto dogma. So there was this inevitable race, let's relive history, to anti-cytokine therapy, like we tried in ARDS or something like CAR T cell cytokine release syndrome. Hey, let's block IL-6 and we're going to save everyone. But the question we were sitting there and scratching our heads and asking about when we were thinking about things that we had studied before was, are COVID patients really dying of a hyperinflammatory hypoxia? And the early clinical experience and some of the data was suggesting that there are similarities between bacterial sepsis and COVID, but there are some very distinct, clear distinctions that differentiate them. And that sepsis, bacterial sepsis, I like to kind of say is throwing kerosene on a fire. So if you think about your immune system, we want this nice crackling little fire, campfire that's sitting there and you can cook your hot dogs over and it's working just right. Keeps you warm, cooks your food. What happens in bacterial sepsis, it's like throwing kerosene on the fire. Huge explosion, lots of collateral damage. And all of a sudden what you have left is burning, smoldering coals that persist for a long time and it doesn't do what you want. You can't cook your hot dog, the embers are flying off and they're burning you, and it's just not working right. What we found, or the impression or the anecdotal evidence we were seeing in COVID disease was that it was actually more like a train coming at you through a tunnel, on the other side of the tunnel. Gets building consistently. The progression of the disease happens over a more extended period of time until finally everything culminates in death. And so we started to ask this question is we hypothesized that COVID mortality is driven more by progressive immunosuppression rather than by the cytokine storm. So this is all great. We wrote a little white paper, we put it in Lancet Respiratory Medicine, and that's all great to think about it, but then we actually have to act, right? We got to do something. We're still just sitting around with idle hands. So what I did at University of Florida, and then Monty and Ken Remy at WashU did, was we asked the question, okay, can we translate and apply existing sepsis endotyping approaches that we've been working on to better understand the mechanisms driving mortality in COVID patients? And so what we did is we took advantage of both UF and WashU had this COVID rapid response funding mechanisms. I'm sure you guys had a similar mechanism here, which really went out to just say, hey, propose some studies, do some research to try to answer problems that we don't understand about this disease that is just falling out. It's like an anvil. And so we submitted through projects through this mechanism. And we had designed our study similarly so that hopefully they could build upon each other because we knew, neither site was going to be able to enroll a ton of patients. And we were the first labs to restart research at our institutions, the entire institution, other than COVID clinical trials. And so we went forward to try to answer this question. And what we found was that, profound immunosuppression rather than cytokine storm is the defining immunologic characteristic of severe COVID-19 infection. So in Ken and Monty's cohort, we showed that both sepsis and COVID have a marked lymphopenia, depressed interferon gamma production, which is a good marker for a failure of the adaptive immune system, the ability to fight secondary infections or the current infection compared to critically ill non-septic patients. And then we also found specifically in COVID, there's an absolutely profound reduction in the ability to be able to stimulate T cells to produce interferon gamma. So just incredibly profound adaptive immunosuppression in COVID patients. And we found in our cohort at UF, very similar findings. It's a very modest early plasma systemic IL-6 response in COVID patients, even though they look like they're inflamed and they have this terrible lung disease. There's a lot of local inflammation, but there's definitely not this large cytokine storm within the entire systemic circulation. And evidence of persistent and progressive markers of inflammation in COVID that was building over time. So if you notice in the blue line, we have TNF out and the alpha IL-6 on the right. Blue line, there's a big explosion of IL-6 and sepsis initially, which then wavers off as throwing kerosene on the campfire I was telling you about. But then in COVID on the blue line, you'll see that there was kind of this progressive increase, TNF alpha and some other inflammatory markers over time, slowly over time over the course of 2 weeks. Well, why is that happening? Because it's supposed to be some explosion cytokine storm. And we were finding these patients were having a significant amount of secondary infections. And those patients that had secondary infections were the patients that were the most floridly immunosuppressed. And showed signs of significant profound immunosuppression by decreased axial ADR expression on monocytes and elevated plasma levels of soluble PD-L1, programmed death ligand 1, which is strongly associated with being in a highly immunosuppressed state. Okay, so yeah, these are tiny little cohorts, right? We enrolled like 30, 50 patients a piece. And so we have to start putting all these pieces of the puzzle together to see if we can make a bigger picture. Is this just what we're finding, or is it apply to others? So other small immunophenotyping cohorts had very similar findings that severe COVID disease, there's robust inflammation in the lungs, but it's not necessarily systemic, or at least in the way that we thought of as being a cytokine storm. There's a moderate amount of systemic inflammation, and there's definitely evidence of innate and adaptive immunosuppression, and specifically in COVID, where they were also finding that the non-survivors from COVID and SARS-CoV-2 infection were having decreased antibody titers of anti-spike COVID antibodies. And so again, there's all these kind of trying to put these pieces of the puzzle together from a lot of different ways, and people were realizing that was the weakness. There were a lot of people all over trying to answer some questions, but it wasn't really a synergized approach. And there was a lot of piecemeal information. So lesson number 3, be a present and involved member of a team, and new and unexpected doors will open. So Mark Atkinson at Florida is a just extraordinary and very accomplished type 1 diabetes researcher, specifically in the autoimmune response. So being funded through the NIAID, Allergy and Immunology Institute at the NIH. He got approached by NIAID saying that, hey, we're putting together a moonshot to try to really understand and better characterize the underlying mechanisms of what's going on with the immune system in COVID. And so Mark knew what Link and I were doing in Florida. And so he grabbed us. He said, hey, you need to be a part of this. And so I became the institutional PI for joining the Impact Network. And so what NIAID did, put together in this kind of COVID moonshot, immunology moonshot, was developing a multi-center longitudinal observation study across 20 sites. We were one of the sites to undergo and do comprehensive immunophenotyping through 28 days of COVID patients, blood, nasal swabs, and then a whole boatload of omics, viral load sequencing, cellular immunophenotyping, proteomics, metabolics, kind of what we were doing on a grand scale, okay? And so what did we find after we got all kind of this thing up and running, and after 2 years enrolling about 1,200 patients? So the clinical phenotypes, so there's 5 clinical phenotypes. Remember I was talking about endotypes and phenotypes. Phenotypes is kind of the trajectory of the patients, what you see. And so these patients, all these COVID patients, or these COVID patients clustered into these 5 clinical trajectories, anywhere from a brief length of stay, they get admitted and then they recover. The y-axis on the scale here is actually, if you just want to think about it, a WHO of disease severity. So 7 is dead and with regards to pulmonary disease, and 1 is out of the hospital. And so there's a phenotype of patients who are sick initially, but then get out of the hospital very quickly, kind of intermediate courses of stay. Then the red and purple lines are the 2 phenotypes where either they're persistently ill and sick and in the ICU with severe disease, but do survive eventually. And the red line is the population of patients that go on to fulminant death. And so there's heterogeneity within disease, right? Not all of COVID disease is the same. Patient trajectories are different. Importantly, we found that the fatal COVID phenotype shows persistent viral load and evidence of decreased function within the adaptive immune system. So this just shows here that this is the fatal trajectory over here. This is viral loads. You can see that all the other trajectories over time are ability to clear the virus. The fatal trajectory, these patients have persistent viral load. They're unable to clear the infection. All right. There's clear evidence that these patients were unable to mount an adequate adaptive immune response. When you look at, this was titers of anti-receptor binding domain, IgG, to SARS-CoV-2, and the fatal trajectory was not able to mount a adequate adaptive response. And then once we finally got the deep immunophenotyping data, it's just started to be finishing out now. This got published about three months ago. And what we found was that COVID mechanistic endotypes are associated with the clinical phenotypes, and there are distinct endotypes within these COVID patients. And so they found 5 modules, what they call them, but basically this is taking a huge amount of data. You have to reduce that down into something that's manageable. And so you reduce it down into kind of these clustered modules that describe the phenotypes. And one important thing that we learned, which is something that we had understood in sepsis and trauma before, is that it's not just a snapshot in time that's important. It's really important to understand the trajectory. Where are these pathways going? What direction are people taking? And it's understanding the mechanisms over time is really important to understand what group or endotype they may be in. There was definitely a group of the pro-inflammatory, so that thought of initial cytokine explosion. Yeah, it's true that inflammation and acute inflammation, especially at type T0, when they're admitted, is associated with the initial disease severity. But really, the ultimate clinical trajectories and the trajectory of death was ultimately best classified by pathways that showed us that there's failure of immune activation and sustainment of a competent immune response, and failure of coagulation and complement normalization, getting those two pathways back to normal. And you guys saw that, right? This is what we're seeing. We're seeing that people were dying of secondary infections, florid multiple organ failure. Respiratory failure was a part of that, but it was always a set of multiple organ failure most commonly. And the coagulation component was interesting because we were seeing that these patients were having thrombosis. There were DVTs, lines were clotting off. You'd pull blood off the patient and it would clot in the tube. So there was definitely a link of very close link of thromboinflammation here. All right. And we also, when looking at the cellular phenotypic data, we saw evidence of PICS-like syndrome. The PICS syndrome that I was telling you about from in sepsis and trauma is subsets of immature myeloid cells are persisting, i.e. you have these immature innate cells of the immune system that really aren't developing appropriately. You just kind of have this, you have this persistent non-functional immune system and florid CD4 and CD8 T cell lymphopenia and functional suppression. All right. So after telling you all this, and we kind of hypothesized that, well, patients are not dying from the cytokine storm. We think maybe they're dying from something else, infection, other mechanisms. So what really are patients, COVID patients dying of? I asked myself, I don't know about you guys, but the first 6 months of the pandemic, I didn't really understand what patients were dying from. Sure, they were sick and on the ventilator, but all sorts of things were happening, right? And so what autopsy studies have shown is that the primary cause of COVID death, really 2/3 of patients, 20% die from florid hypoxia and or pulmonary complications like pulmonary thrombosis, but 2/3 of patients really die from multiple organ failure, recurrent infections, and recurrent shock. So the majority of hospitalized COVID deaths are not primarily of refractory hypoxemia, but rather of progressive multiple organ failure and secondary infection in the context of uncontrolled viremia. Okay, the immune system's not working. It allows the virus to continue to persist, continue damage in the lungs, a lot of local inflammation, turns into systemic abnormalities and leads to death of patients, we think. All right. So the summary of the science is that understanding and differentiating disease endotypes is critical for a targeted precision medicine approach to critical illness. Both bacterial sepsis and COVID are diseases of both inflammation and immunosuppression, but there are differences between sepsis and COVID-19 in their clinical phenotypes and endotypes, and that the majority of hospitalized COVID-19 deaths were not of pulmonary failure, but as I mentioned, MOF and secondary infection in the context of uncontrolled viremia, suggesting that the patients that ultimately die are dying because they can't control the viral infection. All right, summary of the lessons learned, which is what really the message I was trying to get across. I didn't want to get lost in the weeds of 10 years of research, but hey, life's going to dish out lemons, make lemonade. That's all we can do. In times of crisis, resiliency is key. The people around you are absolutely critical in supporting you and keeping you moving forward, but you got to be ready and prepared to pivot. Look for new opportunities that capitalize on your existing strengths and expertise. Use the tools and the knowledge that you have to apply them to a new problem. And just being present and involved and getting yourself involved in things and talking to people always opens doors. Just a couple other lessons that flexible funding mechanisms like these kind of rapid response and moonshot programs give room for innovation and quick response. And I think they showed that they actually did work that way, and the NIH gave us a lot of flexibility in what to do with those funds to be able to adapt quickly. Surround yourself with good people who are much smarter than yourself. And I think that's what I've done by coming back here. And team science, the village fosters resilience. Obviously, it gives you a shoulder to lean on, helps you generate ideas that you never would have thought of yourself, and opens doors and new opportunities. So I hope that was a little bit of an interesting story. I got to acknowledge the village's past, present, and future. And I'm happy to answer any questions, and I really appreciate your attention. I hope you thought it was an interesting story. So thank you very much.